HIV infection can cause a variety of opportunistic infections and cancers. Today, we will be discussing HIV virology and pathology. So, in our discussion, we will have structure of HIV, HIV replication cycle, epidemiology, transmission, evading the immune system, and clinical findings. Starting with the structure of HIV. So, you can see in your screens that the viral particle can be divided into three parts. One is the envelope, two, we have the matrix and capsid, and three, we have the RNA. Um, Among the envelope, we have glycoproteins, GP120 and GP41. These glycoproteins are used for binding to CD4 plus cells. In the matrix and capsid, we have P17 and P24 respectively. And in the nucleus, we have the RNAs of the virus, and we have reverse transcriptase and integrase enzymes. Uh, Point to note here is CD4 plus cells dock with GP120 and GP41. These are usually used as antigens in the test, but due to their high mutation rate, they are not reliable to make a vaccine. But when you see the P24 protein, it doesn't mutate with multiple replications. So we can use this for confirmatory tests for detection of HIV. Moving on, we have HIV structural genes and proteins. Among the genes, we have three main genes in the structure: GAG gene, POL gene, and ENV gene. GAG gene produces P24, P17, and P7. These are the internal group specific antigens that we just saw in the diagram before. The POL gene produces enzymes that are present in the nucleus. There are four enzymes in particular: protease, reverse transcriptase, ribonuclease H, and integrase. And the ENV gene produces GP120 and GP41. Next, we'll talk about the replication cycle for HIV. HIV binds to CD4 plus cells and other cells like dendritic cells, macrophages, and others. The main binding feature that HIV uses is a GP120 glycoprotein that we just saw in the structure of HIV. It binds to the CD4 plus cell receptors and undergoes a conformational change, which produces a new site where a chemokine receptor CCR5 or CXCR4, depending on the cell type, binds to it. From there, there's another change inside the membrane of the HIV envelope, and this change undergoes in GP41, which helps it to bind to the host cell. Now, note to make here is CXCR4 is a chemokine co-receptor that is mostly present in T cells, and that's why HIV cells which use CXCR4 are called T cell tropic strains. And then other cells like macrophages have CCR5 chemokine receptors, and HIV strains that bind to these cells are called macrophage tropic cells. After the cell binds, after HIV binds to the cell, HIV virus RNA enters the cell along with the different enzymes and proteins. Upon entry, there is reverse transcriptase enzyme acting on the viral RNA and duplicating it into a viral DNA. From there, the integrase protein helps the viral DNA to enter into the nucleus and integrate into the host cell DNA. From there, host machinery is used to produce new viral RNA particles and transcription of new proteins as well. Here, new virons are formed with cytoplasmic evasion, resulting in budding of the CD4 plus cells that eventually breaks off and destroys the cell in the process. On a daily basis, a billion viron particles are formed, and these mature viron particles go and infect other cells. Moving on, we have epidemiology of HIV. According to UNAIDS survey, 38.4 million people are currently living with HIV. 1.5 million people are currently infected with HIV in 2021, and 650,000 people have died due to AIDS related illness in 2021. As you can see, we are moving ahead to HIV transmission. Transmission occurs through body fluids, mainly blood, seminal fluid, vaginal fluid, and breast milk. Saliva and tears, they do have some levels of viral load, some viral particles, but they're not significant enough to cause a new infection in the next person. So transmission usually occurs through sexual contact, whether it be male to male or male to female, but more predominant in male to male because of aberrations that are produced and anal fissures that are produced through which the virus can pass from the seminal fluid through the aberrations into the blood. Transmissions are also produced by parenteral infections in cases where, let's say, in hemophilic patients, where they have where they need factor 8 and factor 9 transfusions, and other patients who need other blood product transfusions. In such patients, viruses can enter into the receiver if the blood component is not tested for HIV. Please note that in the first few weeks, viruses are not detected on the test, but they can be passed on if the patient is newly infected from the donor to the receiver. But these chances are so low that they consider about 1 in 2 million cases to happen like that. Now, among the parenteral infections, uh, needle prick injuries, needle sharing, syringe sharing, and all is more common. Uh, Needle prick injuries are common in doctors, whereas the other is common in drug dealers and drug addicts. To be on the safe side, a person who gets a needle prick injury should go for prevention prophylaxis. But it has been noted that when these needle prick injuries or transmission between patient to doctor and doctor to patient, patient to doctor transmissions are higher when compared to doctor to patient. The other way is more on the lower side. Uh, Moving on, we will talk about breast milk transmission. Not only breast milk, there are three ways HIV is transmitted in neonates through the mother. It can be by transplacental path, or during delivery, the blood products of mother are exposed. A neonate is exposed to the blood of the mother during intrapartum, and in postpartum, if the viral load count of the mother is high, it can be uh, transmitted to the neonate through breast milk. So these are different ways you need to be careful of, and you need to think of and plan when giving care for the patients. Uh, Evading the immune system. Regarding this, there are many theories and proven facts as well. Firstly, integration of viral DNA into the host cell prevents it to be destroyed easily. However, there are CD4 plus cells and CD8 plus cells. CD8 plus cells are called cytotoxic cells, whereas CD4 plus cells are T helper cells. T helper cells help to activate these cytotoxic cells, which eventually kill the infected cells. And when there is a high rate of mutation of envelope genes, it's very hard for the the antigen presenting cells to identify new strains and keep memory of that. And when there's lack of memory, it's the virus usually mutates at such a high rate that it can evade the immune system regularly from time to time, leading to a chronic disease. In fact, it has TAT and NEF proteins that are produced, and when these proteins are produced by the virus, they downregulate class 1 uh, histocompatible cells, MHC cells, uh, and this downregulation of MHC proteins help in evasion for HIV viruses, as these are required by T cytotoxic cells to recognize and kill HIV infected cells. Clinical findings: there are three stages or phases in which the patient can present. First is the early symptom or the acute phase, in which the patient usually suffers from headaches, nausea, muscle fatigue, sore throat, swollen lymph nodes, fevers, chills, low blood pressure, calmliness, rash, blueness of skin, joint pains. But remember, these patients can produce in a variety of combinations of these symptoms. Because these symptoms are so generalized, it's hard to identify that this patient can have HIV unless you take a proper sexual history of this patient. In fact, if these patients come to you, it's recommended that you test patients who are more likely to be at risk of having HIV or having been exposed to HIV. As you can see, the graph here shows that there are three stages, as we had discussed: acute, clinical latency, that's the second phase, and then the third phase is the phase of AIDS. In the acute phase, when there's a primary infection, the viral particles shoot off within 2 to 6 weeks, and it reaches a very high level of about 1,000 of about 10 power 6. That's a million. And then the CD4 plus cell counts drops because regular a rapid replication cycle leads to more destruction, and then the CD4 cell counts fall. But eventually, the CD8 cells, which we talked about, cytotoxic cells, they destroy the viral particles, and this destruction brings down the viral load in the next few weeks to months. And when the viral load comes down, the CD4 cell count rises again to such a point that the viral load count becomes steady, and this is called viral set point. And at that point, the CD4 cell counts are also steady to a certain extent, and then from there they stop falling. This phase is called the clinical latency phase, where a person may not have symptoms or may have AIDS-related complex like lymphadenopathies, but because these cells, the CD4 plus cells and other dendritic macrophagic cells, they all replicate mostly in the lymph nodes and not in the bloodstream, thereby uh, limiting the amount of viral virus particles produced. And the activity of CD8 cells also declines with time, as the CD4 cells, which are responsible for activation of CD8 cells, also declines as they're destroyed. A point comes when the CD4 plus cell count drops down to 500 cells per millimeter cube. This is the lower normal limit considered by CDC, and from there on, it reduces down to a point of 200 cells per millimeter cube. Below this, a person is considered to have AIDS, and by this point, inactivation of CD8 plus cells because of the low CD4 cell count raises helps in the rise of viral load in these patients, thereby increasing the viral load to a very high amount and making a person immune suppressed, as the immune system cannot fight without CD4 and CD8 cells. Thus, the person goes into AIDS and this is the AIDS defining condition. And opportunistic infections and cells which mutate internally, causing cancer, are not killed. So, in the clinical phase, the most important things to remember are clinical latency is asymptomatic, acute phase has generalized flu like symptoms, which is self limiting, and then progression to AIDS happens eventually. It may take 7 years or 10 years, but it will happen. If a person has a low viral set point, it will happen later in life. If they have a higher viral set point, it will happen earlier in life, and will lead to immune suppression. And common opportunistic infections can attack a person with AIDS, and eventually, if they're not receiving treatment, they will they will get multiple diseases at the same time and multiple cancers, thereby leading to death. So, take home message: pathology of HIV infections is complex and it can vary from person to person. However, the virus ultimately leads to destruction of the immune system and leaves people vulnerable for opportunistic infections and cancer. Thank you for listening.